All right, Step 2 CK candidates, let's jump right into this high-yield explainer. Today, we're completely stripping away the fluff and building a clinical, authoritative, and fast-paced mastery of the behavioral health core. On the boards, psychiatric diagnostics aren't just about recognizing a sad or anxious patient. Honestly, they're rigorous exercises in pattern recognition driven by strict, non-negotiable chronologies. Simply put, if you don't know the exact timeline cutoffs, you don't know the diagnosis.
Here's our exact roadmap for today. First, mood pathologies and timeline criteria. Second, anxiety and trauma stressor discriminators. Third, the psychotic spectrum diagnostic branch point. And finally, accelerated pattern recognition and trainings. We're going to be heavily emphasizing strict duration cutoffs throughout this explainer, so lock in.
Okay, let's dive straight into Module 1, Mood Pathologies and Timeline Criteria.
Let's systematically tick off these mandatory symptom cutoffs. For major depressive disorder, MDD, you absolutely must have at least 5 of the 9 SIGI-CAP symptoms present for 2 weeks or more, and this is crucial. One of those symptoms literally has to be either a depressed mood or anhedonia, which is that total loss of interest or pleasure. You simply can't diagnose MDD without one of those 2 anchors. Now contrast that with persistent depressive disorder, which you might know as dysthymia. Here, the patient experiences a depressed mood on more days than not, but the timeline stretches vastly longer. We're talking about symptoms enduring for 2 full years or more. So mentally bold these 2 milestones, greater than or equal to 2 weeks for MDD versus greater than or equal to 2 years for dysthymia.
Now, let's look at how we frame the escalation of elevated mood. For bipolar I disorder, the defining feature is at least 1 manic episode. Think of the dig fast mnemonic: distractibility, impulsivity, grandiosity, flight of ideas, increased goal-directed activities, sleeplessness, and talkativeness. This manic episode has to last at least 1 week or be so severe that it requires immediate hospitalization. But what's really interesting is bipolar II disorder. This requires a hypomanic episode lasting at least 4 days, plus a history of a major depressive episode. But you know the ultimate test day discriminator here? Bipolar II strictly features absolutely no marked functional impairment and no hospitalization during that elevated mood. If their functioning is destroyed, it is not bipolar II.
Let's really drive home the comparative logic here. Bipolar I equals mania with functional impairment. Bipolar II equals hypomania plus a major depressive episode, but with fully preserved functioning. And then you have cyclothymic disorder, which kind of sits parallel to dysthymia. It involves alternating periods of hypomanic and depressive symptoms that don't quite meet the full criteria, and this has to last for at least 2 years.
Let's test this with an advanced, board-style vignette. Listen with clinical precision. A 24-year-old male presents with 5 days of elevated mood, distractibility, and decreased need for sleep. He continues to work effectively. He has a history of a major depressive episode. So what is the diagnosis? I want you to hunt for the embedded detail that literally dictates the answer.
The correct diagnosis here is unequivocally bipolar II disorder. Let's systematically eliminate the incorrect option of bipolar I. Why is bipolar I wrong? Because bipolar I requires either a full 7 days of symptoms, hospitalization, or a marked functional decline. Our patient has 5 days of symptoms, which neatly satisfies that greater than 4 days criteria for hypomania, and crucially, the vignette explicitly states he continues to work effectively. That exact phrase is the test writer legally telling you there is a strict lack of functional impairment. Combine that intact functioning with his history of a major depressive episode, and you're forced directly into the bipolar II diagnostic bucket.
Moving right along to Module 2, Anxiety and Trauma Stressor Spectrum Discriminators.
This breakdown brilliantly illustrates the difference between 3 commonly confused anxiety categories. Generalized anxiety disorder, or GAD, is characterized by baseline somatic tension. We're talking about excessive worry occurring more days than not for greater than 6 months, and it has to be accompanied by at least 3 somatic symptoms, things like muscle tension, sleep disturbance, or fatigue. Now, contrast that baseline hum of anxiety with panic disorder. Panic disorder is an abrupt, totally unprovoked sympathetic surge. It features recurrent, unexpected attacks, followed by at least 1 month of persistent worry about having another attack. And finally, social anxiety disorder isn't generalized at all. It's highly specific to the fear of scrutiny, embarrassment, or performance.
Let's look at the trauma duration scale and see how this builds a strict chronological continuum. This is fascinating because the exact same symptoms of nightmares, hypervigilance, and emotional detachment mean completely different diagnoses depending entirely on the clock. If the symptoms last from 3 days up to 1 month following the trauma, it's acute stress disorder. If those exact same symptoms persist for greater than 1 month, the diagnosis automatically escalates to post-traumatic stress disorder or PTSD. And definitely don't forget adjustment disorder. That's when emotional or behavioral symptoms develop within 3 months of an identifiable stressor, but they're completely out of proportion to that stressor without actually meeting the criteria for the other specific disorders.
Time for another high-yield diagnostic check. A 28-year-old woman is evaluated 3 weeks after a severe physical assault. She reports intrusive nightmares, hypervigilance, and emotional detachment, causing significant distress. What's the diagnosis? Really try to isolate the anchor detail here.
Got your answer? It's acute stress disorder. Let's do a rigorous justification here. The clinical presentation is absolutely textbook for a trauma response: intrusive symptoms, hyperarousal, and negative alterations in mood. But the defining anchor for the diagnostic branch point is that phrase, 3 weeks post-assault. You must completely eliminate PTSD as an option because a diagnosis of PTSD can only legally be made after a full month has passed since the traumatic event. Because she's sitting right in that highly specific 3-day to 1 month window, you are forced to select acute stress disorder purely based on that 3-week timeline.
Next up, Module 3, the Psychotic Spectrum Diagnostic Branch Point.
Now we're climbing the psychotic timeline ladder, layering complexity onto the baseline diagnoses we've already mastered. The absolutely crucial point here is synchronizing your thought process with the exact chronological cutoffs that define the primary psychotic symptom continuum. Hallucinations, delusions, disorganized speech, you have to ask yourself, how long have they been happening? If it's between 1 day and 1 month with a full return to baseline, that's a brief psychotic disorder. If the duration is from 1 month up to 6 months, you're looking at schizophreniform disorder. And only when there are continuous signs of disturbance for greater than or equal to 6 months, accompanied by a profound functional decline, can you definitively make the diagnosis of schizophrenia.
Now we need to discuss a massive red flag area where candidates constantly lose points, mixing up psychosis with mood features. Take your time here. You've absolutely got to lock in the distinction between mood symptoms secondary to psychosis versus psychosis secondary to mood symptoms. Schizoaffective disorder requires a major mood episode, but critically, it requires a window of at least 2 weeks where the patient has delusions or hallucinations strictly in the absence of prominent mood symptoms. The schizo part stands completely alone. Conversely, in MDD with psychotic features, the psychosis only occurs during the mood episode. If the depression lifts, the psychosis goes away with it. Finally, delusional disorder involves non-bizarre delusions for at least 1 month, but their global functioning is otherwise remarkably preserved.
Let's map this out with a complex vignette. A patient has 4 weeks of auditory hallucinations and delusions. During the last 2 weeks, they also developed profound depressed mood, anhedonia, and severe fatigue. Diagnosis? Trace the exact chronology of the psychotic versus the mood symptoms here.
The diagnosis is schizoaffective disorder. Let's execute an exhaustive breakdown to prove exactly why. Why isn't it MDD with psychotic features? Well, because in MDD with psychotic features, the mood disorder is the absolute foundation. The depression has to come first, and the psychosis is secondary, happening concurrently. But look at our patient's timeline. They had 4 total weeks of psychosis, but the mood symptoms only showed up during the last 2 weeks. That leaves a critical 2-week window at the very beginning where the patient experienced isolated auditory hallucinations and delusions entirely on their own, completely without any mood symptoms. That 2-week window of primary psychosis legally forces the diagnosis of schizoaffective disorder.
Finally, Module 4, Accelerated Pattern Recognition and Trainings. For this final section, we're explicitly calling out the classic test writer traps designed to trick you on exam day. I want you to step into the persona of a senior attending physician evaluating these cases. Trap number 1, misdiagnosing normal grief, uncomplicated bereavement as major depressive disorder. Do not blindly apply the SIGA-CAPS criteria to a grieving patient. Grief can look exactly like MDD. You'll see sleep issues, intense sadness, and low energy. But you do not escalate to an MDD diagnosis unless there is severe, marked functional impairment, profound feelings of worthlessness, or active suicidality that absolutely mandates that clinical shift.
Trap number 2, and honestly, this is an absolute deal breaker. Confusing bipolar II hypomania with true manic decompensation. Listen carefully. If psychotic symptoms appear, any delusions, any hallucinations, it is never hypomania. The absolute second psychosis enters the clinical picture, the diagnosis instantly and automatically escalates to bipolar I disorder. Psychosis entirely destroys the concept of hypomania.
Trap number 3. Do not inappropriately diagnose schizophrenia before the mandatory 6-month timeline mark is reached. The test writers will give you a patient with devastating delusions, flattened affect, and severe withdrawal. But if the last sentence of the vignette casually mentions the symptoms have been present for 5 months, you are legally obligated to choose schizophreniform disorder. Do not jump the gun on this. You have to respect that 6-month threshold.
And trap number 4, failing to recognize somatic tension variations as generalized anxiety disorder. Muscle tension, severe fatigue, and sleep disturbance lingering over a 6-month period are not just isolated physical complaints. When you see those exact somatic symptoms coupled with uncontrollable worry, you need to recognize that they form the required somatic bedrock of GAD.
Let's wrap this explainer with a provocative thought to carry into your study sessions. In psychiatric diagnostics, the timeline is your absolute anchor. Are you mastering the chronologies or just memorizing the symptoms? As an elite candidate, you have to realize that pretty much anyone can recognize sadness or fear, but differentiating pathology relies on your differential discipline and your total mastery of the clock. Keep refining that pattern recognition, trust the strict duration cutoffs, and go crush those psychiatric vignettes.